Okay, welcome to the Deuk Spine Institute. We are broadcasting live spine surgery shot. Our patient here has had back pain for how many? 6 years. At least 6 years. And his pain is coming from 3 discs, as far as we can tell. The number 3-4, the number 4-5, and 5-1. The last 3 discs in his back. And his L4-5 disc is actually herniated on both sides, left and right. So we're going to be attacking that disc from both sides. The hardest disc to get to is the bottom disc, L5-S1. And it really requires a lot of patience and skill, AP. A lot of surgeons who do endoscopic around the world, and there aren't many, but they won't do L5-S1 endoscopic transforaminal because it's too hard to get to. But we've kind of mastered the technique here at Deuk Spine over the last 17 years. We've gotten pretty good at it. Shot. And we've been very successful at getting L5-S1 transforaminal. The problem is if you don't do L5-S1 transforaminal, you have to do it interlaminar. And interlaminar, there's lots of arthritis here, I can feel it. Interlaminar means that you have to remove bone. Remove bone and ligaments. Shot. AP. Has he had back surgery? All right, good. So you can see all the arthritis on that side. Enlarged facet, enlarged capsule, thickened capsule, full of collagen and scar tissue. But we got through, and now we're getting into that disc. Once we get into the 5-1 disc, we know we can make our incision. We've already numbed things up. Our incision will be a little bigger than a 1/4 inch. It's going to be about a 1/2 inch because we have 3 discs to fix. And to get to all 3, you need a little more room. But if you haven't seen our video on how disc injuries will cause back pain, please watch it. We're going to show it right now. Shot. In the meantime, I'll finish getting into the discs so that we can fix them. Shot. Shot. That's it. Welcome back. Now, you've seen from our video how a disc injury called an annular tear, herniation, bulge. And by the way, slip disc, ruptured disc, degenerated disc, herniated disc, bulging disc, protruding disc, extruding disc, it's all the same. It's basically a tear in the back and the jelly from the center squeezes out. We make 10 different names for the same thing. All right, we are almost done and we're ready for him to test his discs that we're going to be repairing. Now, when I asked him in clinic, where is your pain? he showed me his lower back, this whole area here. And it's pretty typical. I've got one more needle to place on the right side. Shot. And then we're going to put him to sleep in just a minute. But I want to do my discogram first. Remember, we're fixing both sides at L4-5 because he has a double herniation at 4-5. It's on both sides. And he's got leg symptoms on both sides. So I don't want to not treat the right side because he'll be back. He'll have to come back in a year or a few months, and he'll have to have the other side treated. Hold on. Shot. All right, let's go AP. So I've got 3 needles. You can see those, Henry, right? 1, 2, 3, L3-4, L4-5, L5-S1, all on the left side. And now we're going to place the needle on the right side. That looks great. Look at the facet joint there. Very abnormal, enlarged. Shot. Shot. All right, we're slipping in through the foramen. Any questions about the video?
Yes, we do have a question. This comes from Liliana on YouTube.
Okay.
They asked, are epidural steroid injections required before the laser disc surgery?
No, you don't have to have any injections, folks, before you have the surgery. All you have to have is a disc injury that's painful, and it's been bothering you for more than 6 weeks. In other words, many disc injuries, when you have a disc injury, let's say you're playing football or doing gymnastics or something, and suddenly you have back pain, a lot of times the pain will go away on its own. And we don't want to be operating on people if the pain's going to go away on its own. And it's good to have a therapy program while you're letting it heal. But in many people, the pain is chronic. It's greater than 6 weeks. If you have back pain for more than 6 weeks, then you're a candidate for this surgery. If you have a disc injury causing your back pain, which is 87% of people with back pain more than 6 weeks, the disc is the cause of their pain. This surgery will work. So you don't have to have epidurals. All right, is he ready? Now, when I asked the patient, where do you have your back pain? He told me this whole area from here kind of spreads out. And when it gets bad, it radiates out to the side. But it starts in the middle. So we're going to test these discs because these are where I think he has his pain from. But I could be wrong. I haven't been wrong yet, but I could be wrong. I've gotten pretty good at figuring it out. So this is the blood loss we've had, the whole surgery. That's pretty much it. This is about 5 cc's of blood loss. And that's all we're going to have. All right. Are you comfortable? How you doing, my friend? You doing all right? All right. Shot. All right. There's the first disc. He's still a little bit sleepy, so we're going to let him probably snooze. I don't want to wait for him to wake up. We want to move things along. All right. And second shot, big tear. I can feel it leaking out. And third shot. So these are what we call discograms. And discograms, we're injecting a dye into the middle of the disc. It's non-toxic, harmless dye. We're going to go in there and fix these discs, and each of these needles is passing through a tear that's already there. And that tear is where the herniation came out. So the only way to get a herniation or a bulge or a, whatever you want to call it, disc protrusion, extrusion, rupture, slip disc, is to have a tear in the wall. That's step 1, called an annular tear. And then the herniation goes out through the tear and sticks inside the tear. And that's where all the back pain and neck pain or thoracic pain comes from, is the inflammation from that. We call it the interposed herniation. Okay, let's keep going. And Henry, feel free to, what are we doing here, Luis? This looks like L4-5? Yeah, we'll start at 4-5. It's fine. Henry, why don't you show our audience how this surgery actually repairs the tear? Shot. That's why it's called the Deuk laser disc repair. It's been peer-reviewed and published. as safe and effective in the treatment of discogenic pain, which is what this patient has. It's the only surgery that is minimally invasive like this that directly targets the source of back pain. 87% of back pain. Okay, now you understand what the surgery does. We do a debridement. It's called the debridement, surgical debridement. We use a laser to do that debridement. And what we're debriding is the herniation out of the annular tear. And we're also removing inflammatory tissue. We are inside the disc. That's what the inside of the disc looks like. It's stained blue with our special blue dye, the Deuk spine dye. And this dye only will stain herniated disc. It only stains herniated disc. So everything else will stay white. Or if it's fat, it'll be yellow. But the annulus is white, the bone is white, the cartilage is white. Everything is white except for degenerated nucleus pulposus, which is basically your herniated disc. So it actually helps me by showing me where there's herniation left to remove. And you can see the annular tear with the herniation glued, basically glued to the tear. And you can target it with the laser. So this is a targeted type surgery. We do these every week at Deuk Spine. We do them in the neck for cervical disc herniation. We do it in the thoracic for thoracic disc herniation. And we do it in the lumbar for lower back pain and lumbar disc herniation. Now, herniated disc, people usually associate herniated disc with leg symptoms, but herniated disc cause back pain more often than they cause leg symptoms. And you guys just watched the video on how that happens. It happens because the herniation triggers a response from the host body, the patient's body, which is an inflammatory response. And inflammation is what causes the pain because there are little nerve fibers that are normally found in the disc that get irritated by the inflammation. So by removing the source of inflammation and the inflammation, you're removing the inflammation and you're removing the pain source. And that's why this surgery works. It's the only surgery in the world that targets the actual source of back pain or neck pain if we're in the neck. So now other types of surgery don't target the source, which is why they don't work. How many of you know somebody who's had back surgery, they still have back pain? A very common problem, right? It's a common problem. I'm grabbing the I think the needle from the other side, right? I think it's down there. I could feel the needle tip from the other side. I was trying to grab the herniation, I grabbed the needle. It's going to be in there. Any questions, Henry, from our audience?
No current questions.
These are all pieces of herniation, little bits of herniation. Can you guys see the tear? It's right there at 12 o'clock,
Yes, we can.
and it extends down to 6. I've already started cleaning. That's the herniation right there stuck inside the tear, the blue stuff. You see that little golden color? That's calcium. That only happens when the inflammation's been going on for many years. We call it dystrophic calcification. So this is an indication this patient's disc injury is not new, it's old. It's been around for years. And that's why he's had back pain for so long. Okay? There's the tear right there. You guys see it? Right there? And now we're going to clean it up.
Yes, we can.
Thank you.
Oh, we just got 2 new questions.
All right, let's take the question.
This first one comes from Shelby on Facebook,
Hi, Shelby. Welcome.
asking, are you the only one in the United States doing this procedure?
Yes, Shelby, I am. We pioneered this procedure 20 years. How many years ago now? Oh, yeah. We pioneered this procedure let me think. Sorry, almost 18 years. Yeah, 18 years almost. In June of this year, it will be 18 years that we've been doing this surgery. We pioneered it. So yes, we are the only ones. Now, I want you to understand something about the surgery. There's several different parts to it. There's an endoscopic part, which is what you're able to see through a little camera and a tube. I did not pioneer that. That was pioneered by Dr. Parvis Camden, an Iranian orthopedic surgeon back in the early 90s, late 80s, early 90s, back up in Pittsburgh. And one of his students taught me the endoscopic part. So the part of seeing, putting the tube into the disc. But the doctors that taught me, they use grabbers, just metal grabbers, and they use a radio frequency probe. That's it. They didn't use the laser, the straight firing laser. I brought this straight firing laser and added it because when you do the laser, it actually improves the surgery by like tenfold, easy. You can't do the surgery at all without the laser. All you can do is treat maybe leg pain, and it doesn't even work good at that. So that's why a lot of people haven't adopted the surgery is if you don't use the laser, it doesn't really work. You've got to use the laser. And I'm the one who brought the laser, and I'm the first one to do it. But other doctors haven't picked it up yet. They don't know how to do it, and they don't know how to get a laser, for example. These are hard to come by. We actually had to buy a bunch of them. Made a huge investment financially. Overall, we've spent millions of dollars that I borrowed from the bank to build this place and just to equip it. And most doctors don't have that kind of money, and they're not willing to put a personal guarantee to buy it. I was so confident that this is the right thing for patients that I basically borrowed a lot of money to build this place. And the problem is most doctors just do what's easy and what pays well, which is fusions and laminectomies and spinal cord stimulators. So unfortunately, I am the only one right now doing this. But that's not good for you, because you're going to want your doctor to do this surgery. This is the best surgery you could possibly have to fix back pain, to fix a herniated disc, to fix spinal stenosis, radiculopathy, spondylosis. And yeah, we're the only one. But you're welcome to see if you're a candidate. We offer a free MRI review to anybody who wants it. As a matter of fact, our first surgery today was from South Carolina. We're in Florida. We're in Melbourne, Florida, over in the Space Coast, over by SpaceX and Blue Origin and NASA. We're located 10 minutes from NASA. Long story short, our patients come from all over the world to have this surgery because we're the only ones that do it. This patient is from Virginia. The last patient was from South Carolina. Our next patient is from Portugal, over in Europe. And we have people from all over the world. 80% of our surgeries now, the patients come from outside of Florida. They find us on the internet like you have, and they want the best, and they come here for the best spine surgery there is. That's what we offer at Deuk Spine. All right, this is all herniation, and you can see how hard it is even to get rid of it with the laser. By the way, those marks on the metal tube, those are melted areas of steel, where the steel is melted. That's from the laser directly hitting the steel and transmitting energy to steel. So people ask me all the time, can the laser remove bone spurs? Yes. It can melt steel. You better believe it can take bone spurs out. No problem. And very safely, by the way. By the way, the work of this laser, if you look carefully, that glass tube is 1 millimeter. 1 millimeter, folks, that's very small. So this is an incredibly precise tool, much more precise than any surgical instrument out there. This is the most precise surgical tool out there available in the world, is the laser. If I bring it down right here, I could zap 1/10 of a millimeter. So if you look at that glass, it's 1 millimeter, divide it by 10 parts equal. I can easily control the laser just to get 1/10 of a millimeter. I could actually do 1/20 of a millimeter, to be honest. So that's how, but you can only do it by using the endoscope. If you don't have the endoscope, you can't do that. So you need both the endoscope and the laser. All right, we're just at the end of the disc. This is our first disc, and Dr. Berndes is doing an amazing job with this patient because this is not an easy patient. Patient's overweight, and he has sleep apnea, right? So, you know, most doctors won't even do surgery on a patient with overweight and sleep apnea. They just tell them to go lose 100 pounds and come back when their sleep apnea is gone. They don't. You can't. That's the whole point. You can't. So these poor people do several things. They live in pain. Their lives are miserable, like the last guy we did. He's in a wheelchair. Came to us in a wheelchair from South Carolina. I said, why are you in a wheelchair? He said, because my back hurts so bad I can't walk. If I get up, it starts hurting. I gotta sit down right away. That's no way to live life, folks, in pain, especially when it's fixable, huh? Yeah, he's already feeling better. He has to feel better because we fixed his pain, right? It's impossible not to. So my point is, these patients like this one, they get overweight because they can't do anything. Their lives suck. And they either just live in pain or they treat their pain with drugs, alcohol. Some of them, unfortunately, some people even, end their life because they can't find a way out of pain. And we want people to know you don't have to do that anymore. Back pain is now curable at Deuk Spine Institute, but we're the only ones that can do it. I mean, anybody can do this, but you have to have the equipment, you have to have the training, you have to have the expertise and the staff and the right medications and the right stuff. But you also need to be able to make the right diagnosis, because if you don't treat the right place, you're not going to get pain relief in the patient. You got to go for where the pain comes from. And Deuk Spine is a world leader in diagnosing pain. We know where pain comes from.
We have another question.
Yes.
This comes from Liliana once more on YouTube. Asking, is there a waiting period for patients who get the epidural steroid injection prior to surgery?
So if you're getting an epidural and you want to know when is it going to take effect, epidurals work usually anywhere between 48 hours to 2 weeks after the shot. If 2 weeks have gone by and you're still feeling miserable, then the epidural is not going to work. Okay? It takes up to 2 weeks to start working. Epidurals do not fix these problems, folks. The problem with the disc and the pain coming from the disc will never go away with an epidural. It may get better temporarily. It may get better for a few weeks or a few months at most, but that pain will always, always, always come back. It's just a matter of time. So epidural is not a cure. An epidural is just a temporary Band-Aid for some of the pain you're experiencing. This treatment right here that you're watching is a cure. You don't need epidurals after you have this treatment. All right, we're just about done. You can see the blue I'm almost done. I've gotten, and I always tell people, by the way, when you take a herniated disc and you treat it with surgery, the most you're ever going to get is about 70%. You're never going to get 100. There's no surgery on earth that gets 100% of the herniation. It's not possible. And that's because of the angles that we approach it with, okay? And that's because of the tools we have available. But there is no surgery that gets 100. You don't need 100%. You need about 50% of your herniation removed, okay? But you need the right 50% removed. Not just any 50%, the right 50%. Okay, there's the nerve root right there. And let me just take one more peek. I think we're just about done here. I'm going to zap that last bit and we're done. Keep the questions coming, folks. I've got answers for most of them.
No current questions, but we do have a comment from Shelby, once more on Facebook, following up her question if you were the only person in the United States doing this. She said, thank you. Okay, I thought so. We have consulted twice. We are currently wanting to work with you, hopefully on insurance. I need you, and yes, you have me only wanting you.
Well, I appreciate that. You know, insurance companies are really difficult because the truth is, insurance companies, all they want to do is take your money and not pay for your medical care. They're not there. They're not your guardian angel. They're not your saving grace. An insurance company is a business. It makes money when you give them more money than you use. So spine surgery is expensive, all right? And, you know, if they can deny your spine surgery, they can save a lot of money. So they do. They deny spine surgery all the time. Not just the laser surgery, but all kinds of surgeries get denied. Fusions, laminectomies. And they'll deny anything they can get away with denying. Okay? And I've seen them deny surgery on children that need brain surgery to take a tumor out. They'll deny it. They'll deny a child who has a brain tumor and needs it taken out. They will deny that surgery. They do it all the time, okay? And it's shameful. So I learned long ago insurance companies are not your friend. They're not the doctor's friend. They're not the hospital's friend. We're constantly battling them to get them to pay for surgery and treatment or tests that patients need. And they say to us, look, we're not practicing medicine. We're just telling you we're not paying for it. Okay, well, there's no difference. When they sit there and tell you the treatment you're recommending is experimental or not necessary, they're basically practicing medicine. And people should know the truth, okay? Now, the only way we're going to fix this problem is if we fight the insurance companies together. We've got to get them to start doing what they're meant to do, which is to pay for your medical care. And the only way that's going to happen is if you fight them. And we are fighting them. We're one of the few companies that fight the insurance companies, okay? We're not the only ones, thank God. There's others. But the truth is, the insurance companies have more money than God. They are very powerful. Shot. And they've got the best lawyers. They've got the best business people. They've got the best psychiatrists. Shot. They do everything in their power to steal your money and not give you medical care. Shot. And so, you know, we're just a medical company. We're not lawyers. You know, we're not really trained to fight them. We're just trained to provide medical care. And so I've had to hire very expensive lawyers and pay them almost $1 million so far to try to fight for my patients to get their surgeries paid for. And I do it because I believe it's the right thing to do for people, for humanity. Because I want people to be able to have access to the best care available. And I don't want insurance companies limiting people's ability to get the best medical care, at least not when it comes to spine. So we're getting ready to fight Blue Cross Blue Shield, for example, and United, and eventually Cigna. We're going to take them on, and Aetna, and we're going to take them to court, our patients are, and we're going to try to get them to pay for the surgery. Okay? But this is it's taken us 16 years, to get this far. All right? 16 years of fighting them. And we do get payments from them from time to time, but it's not consistent. We don't have a contract with them for the surgery center, so they get to pick and choose when they want to pay, and they don't want to pay. So I would say we may get, if we're lucky, we may get 10% of our claims paid without a big fight. And right now we're gearing up for the big fight. So that's the situation with insurance. I'm sorry that you're struggling with it. Believe me, if I could fix it, I'd fix it. And I'm trying. And it's taken me $1 million in paying lawyers to try to help patients to get their bills paid. I'm paying for that. I'm not supposed to pay for it, but I want to help people get this procedure because it's better for them. So I've spent $1 million of my money to help people get their surgeries paid for. And it's going to take a big fight in court, and that fight's coming. It's going to come this year. It's about to happen. I'm just waiting for the lawyers to decide how much money they want from us before they agree to do the surgery. Before they agree to do the lawsuit, because it's a contingency lawsuit, meaning that the lawyers aren't going to get paid unless they win. That's the only way to do it. So that tells you it's a good case, because the lawyers won't take a lawsuit on contingency unless they think they can win. So it's taken me 16 years to get to the point where we've got the files and everything and the data and all that stuff to where it's perfect, and we can fight these guys to get them to pay. Because that's what we need to do. We need to try to get them to pay. Insurance companies are supposed to pay. We want them to pay. They need to pay. Patients should not be paying for their medical care. Insurance companies should be paying for their medical care. All right, we are in the herniated disc. This is the one we didn't get a lot of dye in because it was, just leave it. It was kind of scarred up. And you can see there's a lot of scar tissue at this disc. This is L5-S1. Okay, and this stuff is hard. I feel it's hard. And it's pushing on his nerves real bad. So it's crushing his nerves, and that's why he's getting weakness in his legs. Okay? Look at all that scar tissue. That white stuff there right in front of us, from the bottom of the laser all the way down to there, that's all scar tissue from chronic inflammation from the herniated disc. It's just irritated the heck out of his inflammatory system. His body has been fighting it for years, trying to clear it out. It can't clear it out, so instead it makes scar tissue around the nerves. And that's where we're working right now, right around the nerves. The nerves are just outside this metal box, this tube. All right, any questions?
Yes, we have a couple questions. This one comes from Van on YouTube. And Van asks, can you treat a slip disc with the laser?
Yes. Yes, we can, Van. So what I was saying earlier is that we in medicine, we've got a lot of names for the same thing. Slip disc, bulging disc, ruptured disc, extruded disc, protruded disc, herniated disc. I think that's most. Degenerated disc. It's all the same thing. It is a tear with a jelly in the center is squeezing out through the tear. And that is the slip disc. Look at that right there. You see that? There it is. You guys see that? That's jelly squeezing out through the tear. That's what a herniation is. But in this case, it's mostly scar tissue. Okay, that's why it's golden color. Scar tissue. How's he doing? So far, we're doing pretty good. He's got a lot of scar tissue at 5'1". All right. So to answer your question, yes, we can. Look at the inflammatory tissue. It's pink. Okay? Keep the questions coming. Happy to answer them.
This next one comes from SH, I'm just going to go with that, SH on YouTube.
Uh-huh.
And then they asked, I heard Dr. Deuk mention your MRI will look different after the Deuk laser disc repair. Could you describe what that means?
Yeah, what I said was your MRI will not look that different. Maybe you misunderstood. So I apologize for any misunderstanding, but what I tell people is don't expect your MRI to look different after this surgery. Here's why. Do you guys see this space here that we're operating in from side to side? That's 5.5 millimeters. It's basically 5 millimeters. Okay? The resolution of an MRI is about 5 millimeters, the typical MRI. In other words, you're not going to see much of a difference because we're operating in such a small area. We're not trying to get your disc herniation 100% gone. We're trying to get the part that's hurting you gone. And that's what we're targeting, is the painful part of the herniation. So we're not here to make your MRI look normal. We're here to fix your back pain that comes from the herniated disc, or fix your leg symptoms that come from the herniated disc. We're not here to make your disc look normal. Your disc will never look normal once it's been damaged. There is no surgery on earth that will give you a normal looking your own disc. None. Once you've damaged it. None. The Chinese are working on transplanting a dead person's disc that's normal into a living person that had a bad disc. That's the closest you're ever going to get to a normal looking disc. But I strongly recommend you don't do that. It's very dangerous and totally unnecessary. This surgery is going to have far better results than any other surgery out there. See the inflammatory tissue there, pink? That's, well, the bone fuses. So they'll cut half of vertebral body above, half of vertebral body below. They'll cut out the disc that's bad, half of vertebral body. They'll do an osteotomy. And then they'll just lay in and it'll do a bone-to-bone fusion that will have to happen. Now, of course, you got to do it while you're immune suppressed, right? Because you got to suppress the immune system, which means you're exposed to diseases that AIDS patients get, you know? All kinds of horrible infections. Kaposi sarcoma. Cyclosporin, yeah, it's an organ transplant. I would never get a transplanted disc, ever. I would die before I get a transplanted disc. This is the surgery you need. It's simple, it's totally effective, it's the best surgery out there. You don't need a normal looking disc. Who cares if your disc doesn't look normal? We don't do spinal cosmetic surgery, ever. We're not here to make your spine look good. We're here to make it feel good. You want to look good? Talk to God. God's the only one that can make your spine look better. All right, just about done. Another, let's see where we are. There's the end of the disc right there. Okay? We're on the outside of the disc. We're looking in. You can see the tear. He does not like this. Look at all that scar tissue I was talking about, all right? Life is so short.
We have another question.
Sure.
This comes from Spyros on Facebook.
Spyros. Is he Greek?
I believe so.
I hope so. All right, we'll take it.
This third question is, how do you know when a DPR is necessary? How do you know if you re-herniated a disc?
Spyros, great question. So there's a few things you can do. Number one, on the physical exam, I can tell if somebody has facet pain by examining them, by putting my fingers where their pain is. Okay, facet pain is tender. When you patient has pain and they're standing up in front of you and you push on their facets, they will go, ow, ow, it hurts. That's facet pain. You can never push on a disc herniation. There's no such thing. So if the patient has tenderness on exam where their facets are, that is facet pain. They need a DPR. Okay? And then as far as reherniation goes, if they don't have facet pain, we're done. Okay? The nerve is right up in that fat, so we're done here. Now look at the tear. Okay, the inside of the tube is 5 millimeters. That's 3 millimeters, so the tear just has to close 3 millimeters. If the patient does not have facet pain, and you rule out the SI joint, you rule out the piriformis, and they have axial pain, dead center, over a disc, you look at the MRI, and there's a disc problem, then the disc is the likely cause. And you can confirm it with a discogram. The other thing you can do is you can do a facet block or a medial branch block, and you can treat the facet pain temporarily, get rid of it with numbing medicine. If it takes the patient's pain away, then you know you are dealing with a facet problem. Okay? That's how we can do it. But we've gotten so good, we don't need to do medial branch blocks anymore. We just can tell on exam, on the physical exam. Okay, done with 2 discs. One more to go on this side, and then we're going to go to the right side and do our last one. Great questions. Keep them coming.
We got a couple more. This next one comes from SH once more on YouTube, asking, what if after the Deuk laser disc repair, part of the same pain remains after 9 months with no facet pain?
What if after the Deuk laser disc repair, part of the same pain remains? So we have never had a patient that we did the Deuk laser disc repair on a disc that the disc pain didn't go away. So if the patient still has pain after the Deuk laser disc repair, that means their pain is coming from something else, but not the disc that we operated on. Unless the patient reherniates the disc. That's the only time the disc that we operate on will cause pain, is if the patient reherniates the disc. So if you have pain that you had before surgery and you had the Deuk laser disc repair, either you reherniated your disc or you have pain from something other than the disc. But we've never seen disc pain not go away with this surgery. You are more likely to encounter aliens that come to your house and ring your doorbell than you are to have disc pain after this surgery, unless you reherniate your own disc. The reherniation rate is 1%. That means 1 in 100 people will reherniate a disc that I fix. And most of the time they'll be honest and they'll tell me, I was doing something I shouldn't have done. And sometimes they don't tell me what they were doing. But 9.5 out of 10 times the patient knows what they were doing wrong. They just may not want to admit it. And the other 5% of the time, they don't know what they did. They don't have something that happened. But usually it's bending over, picking something up, carrying something heavy. We had one patient who reherniated fishing a grouper, 100-pound grouper, 7 weeks after surgery. 7 weeks. And, for the first year, you're not supposed to lift over 40 pounds. He was lifting a 100-pound grouper. And he pulled it out of the ocean with a fishing pole. So those things fight harder than 100 pounds. They'll fight 200 pounds, with that tail. Anyway, so I don't know if that answers your question, but if you have pain that you had before surgery, after surgery, it's not coming from the disc we fixed, it's coming from something else. And the best thing you can do is find out what it is and get it fixed. And if it is coming from the disc we fixed, then you reherniated your disc. You did something you weren't supposed to do. Yeah. Just to give you an idea, we've done this surgery on 2,000 patients almost. We're about 50 short of 2,000. So, and the average number of discs that we fixed is 2.2. So do the math. That's 2,000 times 2.2. that gives you 5,000 discs, okay? 5,000 discs in the last almost 18 years. 5,000. And if you had one disc operate on me, you're 1 in 5,000 discs. So just think about that. We have 5,000 discs of experience to your one disc. So we understand this. We know exactly the outcome. It's very predictable. It never changes. And, it's reproducible. So if there's pain in your back or neck after the laser surgery, it's not coming from the disc we fixed, it's coming from something else. And the best thing to do is to set up a telemed. Let me try to figure it out, or come here in person, which is even better, and let me try to figure it out. All right, next question.
Next question comes from Betty on YouTube.
I'm getting liquid on my feet. Hi, Betty.
Betty asked, "Hi, on my report it says combination of Modic type 3 and 1 changes. Can you explain? Thank you."
Yeah, Betty, so modic changes are structural findings that seen on MRI usually, or diagnostic imaging like X-ray, CAT scan, MRI, that occur at the disc, and they're an indication of degenerative disc disease. So there's modic type 1, 2, 3, and even 4. And they basically represent end plate changes and disc collapse, irregularities of the end plate, bone spurs, pitting, subchondral cysts. I mean, there's a whole bunch of stuff. But in the end, it just means you have a injured disc that's degenerated. So it's been injured for a long time. This is totally fixable. Your symptoms, if you're having any from the disc, can be fixed with the laser surgery you're watching now, and that's what I would recommend. Your disc will never look normal. You'll always have modic changes your rest of your life. It doesn't matter. Modic changes are like wrinkles. They don't bother you. They're just there, okay? Now, it bothers some people, but it doesn't affect you functionally. For example, the only type of wrinkles that affect people functionally are wrinkles around your eye, which they can affect your vision. That's the only time wrinkles can really functionally affect you. Okay, they can affect you psychologically, but not functionally. So modic changes never affect you functionally. They don't cause any type of symptoms whatsoever. Zero. Zippo. They're kind of like you might see sometimes a hemangioma of the bone. You might see facet arthropathy, facet hypertrophy. You can see lots of structural abnormalities, things that are not normally found. Okay? They're commonly found, but not normal. Common and normal are not the same thing. Okay? Normal means that it's normal, like that's a normal thing, normal structure. Common means lots of people have it. So it's very common to have structural changes in the spine, like modic changes, but they're not normal, no matter what anybody tells you.
We have a couple more questions.
Yeah, we'll take them.
This next one comes from SH once more on YouTube. And they ask, what tests would you run to CK for reherniation? I think it means to check.
You can do an MRI scan if you want to look for a reherniation.
Next question. This comes from Roscoe, once on YouTube, asking, what is the correct way to treat cervical foraminal stenosis? I have heard of foraminotomy.
Yeah, Roscoe. So there's different ways. Stenosis means narrowing, Foraminal stenosis means narrowing of the foramen. The best way to treat symptomatic cervical foraminal stenosis is with the Deuk laser disc repair, the surgery that we do with the laser endoscopically. That's the best. There are other ways you can treat it. They're not as good, they're not as effective, they don't work as well, or they're more invasive. They have a higher complication rate. They cause instability or structural damage during the surgery, or you have to take narcotics afterwards for pain control from the surgery because of all the damage done by the surgery. So foraminotomy and laminectomy are two types of surgery that can be used to treat cervical foraminal stenosis, but they're very damaging. The surgeon has to rip out bone and ligaments from your spine, permanently weakening your spine, permanently damaging your spine during the surgery. I would not allow that to happen. The laser surgery we do is the best way to fix it, and there's no damage to your spine. An ACDF is another way, anterior cervical discectomy and fusion, to treat cervical foraminal stenosis. Again, I wouldn't recommend it. The complication rate is 50%. Everybody takes narcotic opioids afterwards for a long time, and you got metal in your neck. You don't want metal. God wanted metal in your neck. God would put metal in your neck. So don't let man put metal in your neck. Right, Luis?
We have another question.
Uh-huh.
This comes from SH once more on YouTube, asking, so even though MRIs don't look normal, you can find the reherniation. Is that what you were saying? And thank you for taking my questions.
So SH, to find a reherniation, you would have to know what the MRI looked like immediately after surgery to see if there's a difference. And you would have to get the MRI so it cuts exactly through the disc as the prior MRI or the next MRI, which they don't. You're never going to get the same picture. That would be like trying to take two pictures of a person in a park on different days and have the picture exactly the same. It will never be exactly the same because you're taking pictures through different parts of the spine. The MRI scan is not a picture, it's actually an average of signal. So a lot of people don't understand that. It's not an actual picture. Look at that piece of herniation. But the best test we have for reherniation is the MRI, even though it's not perfect. I personally would never order an MRI on a patient unless I was fairly certain they had a reherniation and I had ruled out all the other causes of pain that they could have by my physical exam. So, but if you want to know if there's a reherniation, MRI is your best test. Yeah, we got one more level to go. And on the other side, and then we're done. Yes, our next patient is from Portugal. He flew all the way here just to have his back fixed. He has 2 disc herniations, L4-5, L5-S1. 6 years of back pain. He's got actually pinched nerves on both sides, but he only has weakness on the left side, the side that we're going in on. Nikki, you're such an encyclopedia. I love it. Thank you.
Nikki knows the patients really well.
Yeah, she should.
Almost as well as Dr. Merkel.
Ha 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 ha. You know them internally. She knows them externally, superficially. You like that? You did internal medicine, right? Or did you do surgery?
Surgery.
So you never did medicine?
No.
Yeah, most people who do anesthesia do internal medicine. But you were thinking about being a surgeon.
Well, see, when you do a lot of cardiac anesthesia, you become a good internist.
Yeah, that's why I said you know them internally. Because of internal medicine. All right, let's get the grabber. I think there's a few more pieces of herniation deep down. Look at that. There's one. That should be it. I don't really see any more. Just some little stuff. Let's clean this up and then we'll be done. Got about 2 minutes left on this disc. Keep the questions coming, folks. Happy to take them. Happy to share my knowledge and experience with you. There's the end of the disc right there. You see that? There's some fat at 12 o'clock. That's the epidural space, medial. We're looking at the paracentral region of the disc here, posteriorly. By the way, if you were to show this video to most neurosurgeons that have never looked at these endoscopic pictures, never, they would really not know what they're looking at. Now, some of them would get that that's epidural fat, but the truth is, this is not a view that neurosurgeons are trained on commonly. I had to go to special training to be able to do this surgery. Training overseas. And some training in the United States. But this endoscopic surgery was not part of my training. And I trained at a top neurosurgery training program. This is a sort of a newer technology. All right. Well, look at all that scar tissue. That's a giant wad of scar tissue. Massive. Good news is that it's not outside the disc, it's inside the disc. And that's why the dye would not be seen here at this level. Because this thing was blocking it from leaving. Now, we're not here to take all the scar tissue out. That's not going to help this patient. We're here to get rid of his back pain, and we've already done that. And his leg symptoms. All right. I don't see any free fragments. Nothing just floating around. All right. That should be it. Let's see the grabber one more time, and we're done at this level. This is L3-4. Pretty badly damaged. Keep the questions coming. Happy to take them.
No current questions, but we do have a comment from SH saying, hope we can come back in and find the source, of after surgery pain. Thank you.
Yeah. Happy to try to help you out there, SH. About 25% of our patients, 50% of our patients have other kinds of pain besides their disc. And about 25% of our patients have to come back and get another treatment at some other source. So if you're having pain, you're in that 25% pool. It's always good if we can identify all the pain sources when the patient's here in our clinic before surgery. But sometimes we can't because the patient's not having that pain at that time. But if they are, we will find it. So if if SH, for example, who said that they've had surgery here, we don't know who SH is, but I'm just going to say, if SH has pain in the area we operated, then either they didn't have that pain before surgery, or they had the pain, we diagnosed it, we recommended a treatment, but they chose not to go through with it. But it's very rare that we would miss a source of pain because we check for all of them on every patient. So either it was developed after the surgery and they left, or they didn't have it at the time that we saw them. It's extremely unlikely that we miss it. But it's not 100%. Could be we missed it. All right. We're going to make an incision. We've already fixed 3 discs. We're going to go for number 4 on the patient's right side. This is the L4-5. Remember, this patient had herniations at L4-5 on both sides, and those herniations were pushing on the nerves. And I'm going to tell you something. Looking at how hard these discs herniations are because of all the scar tissue, it doesn't surprise me he had so much nerve pain or nerve symptoms because his nerves were being crushed. And I think he had weakness, right? Yeah, he had weakness. So weakness means the nerves were being pinched. Okay? And that scar tissue that I just showed you with the laser and the scope, that scar tissue is really hard. It will crush these delicate little nerves. And that's what's happening. So we just got rid of it on that left side. Now we're going to get rid of it on the right side. So at this point, his back pain should be gone because we fixed the tears. However, the leg symptoms on the right side is what I'm more worried about. The leg weakness or findings from pinched nerves. Shot? All right, at this point we're advancing the tube. Now, have we shown both videos?
Yes, we have, yes.
All right, that's it. So remember, we're doing the L4-5. Everyone agree? Yep, we already did the left side. So you're going to see a little bit of blood inside the disc because, remember, we operated on the other side, and there's a path between one side and the other side of the disc. So I wouldn't be surprised if there's some blood inside the disc. Let's get the scope on, please. Yep, there it is. Uh-huh. Thank you. Wow, look at all the chunks of herniation. Very hard. All right. Any questions, Henry? So we'll be done in about, 8 minutes, doctor?
At this moment, no current questions.
Our next patient is from Portugal, and he's having two discs fixed. He comes from Lisbon. If you've never been to Portugal, I think Lisbon is still the capital. It's where most people will fly into. I know that when I've been to Portugal, that's where we flew into, was Lisbon. And my son and I used to race in Portugal. I didn't race, he did. But the world championships in go-kart racing, they love the tracks in Portugal, especially Portimao. See the herniation right there?
Yes, we do.
Portimao is south in southern Portugal. So you'd fly into Lisbon and then head south for about 2.5 hours to Portimao. And they have a beautiful racetrack there. I mean, truly a world-class racetrack for go-karts and cars. As a matter of fact, Formula One had some races in Portugal a few years ago at that track. And the city, Portimao, is actually on the ocean. So the seafood there is really good.
Kind of like paella there, right?
Paella? I don't know. Paella is Spain, I thought. No? Maybe you're right, though.
There's some crossover. I don't know. I think in Portugal, they say it's the #1 place for American expats.
Really?
So I heard.
It's got some amazing surfing, I can tell you that. We would pass this place, this world famous surf place. Of course, I don't surf, but
Beautiful country.
oh, yeah, beautiful. It's getting more and more expensive to live there, though, I heard. You know?
Madeira.
We have another question.
Sure.
This comes from SH once more on YouTube, asking, will this current patient's nerves likely regenerate or heal?
So the nerves will heal by regenerating. And what I mean by that is there's 3 types of nerve injuries that can happen. There's what's called a neuropraxia, which is the mildest form. That's the one you want. That's where the nerve is crushed and it's like a bruise to the nerve. I got it. And it basically, the nerve stops working properly but it heals over time. It just starts to work, physiologically work. Then you have a crush injury that causes fibers to, basically nerve fibers to break. And as long as the sheath around the nerve is intact, it hasn't been compromised or damaged, the nerve fibers will grow back, they'll regenerate down, and they'll eventually reach their targets, which is skin and muscle and joints, and sometimes organs. And that's the second, type of injury. And the third is a transection, where you actually cut through the sheath of the nerve. Now, herniated discs don't do that. Herniated discs don't, they either do the first or second type. They don't do the third type. Cutting through is like trauma, an accident, a knife wound, a bullet wound, an avulsion where you're ripping, motorcycle accident, car accident. Those types of injuries can rip the nerves right in half. And then there's no healing. Those types of injuries don't heal. So we're hoping that, yes, the nerve will heal by regenerating and growing back. But, you have to have an intact perineurium and epineurium to do that.
We have another question.
Sure, it's
Come-
coming.
This comes from Spiros, once more on Facebook, asking, how long is best to wait between a first and a second DLDR surgery? Dr. Deuk and his team are awesome. Thank you.
Well, how long is it to wait? How long is it best to wait between a first and a second DLDR surgery? Well, if it's, you should only have one DLDR surgery, but unless you're talking about different body parts, right? So if you're talking about thoracic and lumbar, you can do them at the same time. If you're talking about cervical and lumbar, we do those a day apart. So a patient can have their lumbar on Tuesday and their cervical on Thursday, for example. The last patient today is that case. We're going to be doing her thoracic and lumbar today, and we're going to be doing her cervical on Thursday, 2 days from now. Okay? So we do that all the time. Because people that travel far, they don't want to have to come back. So they just want to get everything done and God, look at all these pieces of herniation.
So we always do our best to accommodate people from out of town to get both done.
Yeah, we always do our best to accommodate people from out of town. Normally I would, I'd put a few weeks, but there's nothing wrong with doing the surgery 2 days later. As long as the patient is medically fit and has, met with the anesthesiologist. Look at that piece of herniation. Look at that, Henry. I mean, that's just one of many pieces. You see that?
Yes, we do.
Just popped out. I mean, look at the size of that. Go ahead, Luis. That's over 1.5 centimeters. It's about 1.5 centimeters long. So, just, this guy's disc is just fractured massively. I mean, he just blew it up. Whatever he did. I don't know if he worked in construction for many years. So, yeah, I mean, all this stuff is going to be gone, right? And the disc will be more collapsed, but he won't have the pain or symptoms. There's a name for this. It's called internal disc disruption. I didn't make it up. It's been known for many years. And it basically is a shattered disc. When you load the disc so forcefully that it just blows the disc apart. Kind of like when you have your tire blow on your car, right? Like we all get punctures, but blow-ups are rare. This is a blow-up of a disc. Now it doesn't matter that it's blown up. We can still repair it, like we are. And this will still fix his problem. He won't have the back pain from the disc. He won't have the leg pain. And he does not need a fusion. All right, keep your questions coming. We've got a few more minutes left.
So far at this moment, no current questions.
Thank you. Another piece. Look at this one, Henry. Bring the other one. Just took out 2 monsters. You see them? Luis is showing them to you. Henry, we need to hear from you. Henry, are you there?
Can you hear me? Oh, there we go. Sorry. Oh, my bad. I thought I turned my mic on. But yes, no, we see it, looking at him perfectly with the ruler and all that. Looks great.
All right. Remember, this is L4-5. Berndes, I'm just getting so much herniation out of here. Didn't expect the whole disc to be so badly damaged. There's your tear right there. You can see it clear as day. We should be at the end of the tear right here. Want to clean this up? Huh? Yeah, we got just a few more minutes. We're done. This should be the last section. It's just kind of surprised me with how much herniation he's had here at 4-5 on the right side. All right, folks. Gonna wrap this up in just a couple of minutes. If you have questions, feel free to ask me right now. Type them up. Otherwise, I'm gonna be done in just a minute here. I'm gonna go see the next patient and do our timeout. And then we'll get him back. He's our Portuguese patient. These are always the hardest, these big blows. Jeez, this just goes on and on, huh? See that? Remember, we already did this disc repair on the other side, just 15 minutes ago. And you saw the huge pieces of herniation we fished out. Wow, Louise, look at that. More. This is like the never-ending disc. I think his spine is a little bit rotated. Got a little bit of scoliosis.
We have another question.
Sure.
This comes from SH once more on YouTube,
Sure.
asking, please, who do we call for the recheck to find the source of after-surgery pain?
You would talk to MRI Review. Just go to our website and type in mri.dukespine.com. I don't know where you live, but I assume you're not in town. Otherwise, you can just come in and be seen. But if you're out of town, far away, you don't want to drive in, no problem. We can start with a Zoom and see if we can figure it out with Zoom. So who was, SH, who was your scheduler for your surgery? Ask SH who their scheduler was.
Not a problem.
Huh?
Not a problem. Doing that right now.
Say, who was your scheduler for your surgery? All right, I got probably 1 minute left here. I can see that we're at the end of the disc.
Just asked him. Currently waiting an answer.
Well, you might not get an answer. I can't twist this. I can't twist it still. You got to get it off of that drape. It's got to be able to move. You're doing good, just lay still. Well, SH, who is your scheduler, SH?
Currently waiting for an answer.
You may be waiting for a long time.
They just replied, I am checking.
Huh?
They just replied back saying that they are checking.
Okay. You'd think they'd remember the scheduler. But we do have a lot of people here. So. All right, this should be our last bite and we're done. 8. Yeah. That's it. Not a mess. There's the nerve. You know me, Luis. Just can't help myself but to go back in. Huh? You got me. You got my behavior down. So, interesting. So who was SH's scheduler?
They They just replied back, so sorry, I have not found the information. I was not patient or not a patient.
I was not what?
They said I was not patient.
Oh, well, I thought they were saying they've had surgery with us.
I thought so as well.
All right, well, I didn't think so. That's why I didn't think they would answer. Okay. Let's go ahead and end the broadcast. We're done. Scope off. Henry, end the broadcast.
Not a problem.